I'd like to introduce you all Dr. Rajeshwari. We have Dr. Vijaya. Thank you for being here with us today, ma'am. I now request Dr. Esther and Dr. Udhaya Preethi from SRM Medical College to present us on the topic IUGR.
Good morning. Today we are going to present. Anomalies were noted. No history of high BP recordings, no history of pedal edema or decreased urine output or epigastric pain, no history of headache, no history of high sugars. On third trimester, patient able to perceive fetal movements well. Ultrasound was done at 32 weeks, which showed some difference in the growth of the fetus. A repeat scan was done after 2 weeks, which showed no significant increase in growth. And she was told that last ultrasound taken 2 days back showed mild changes in the blood supply to the fetus and was advised hospitalization. No history of high BP recordings or pedal edema, no history of pain abdomen. Past history, no history of diabetes, hypertension, asthma, thyroid diseases, tuberculosis, renal diseases or connective tissue disorders or cardiac diseases. Personal history, no history of smoking, alcoholism or drug addiction. She consumes a mixed diet and she had adequate calories and protein intake per day. Family history, no history of diabetes, hypertension and no history of any multiple pregnancy or congenital anomalies running in the family. On examination, she is moderately built and well nourished. Height is 156, pre-pregnancy weight 60 kg, present weight is 69 kg with a BMI of 24. Weight gain in pregnancy is 9 kg. Vitals, blood pressure being 120/70 measured in left upper arm in semi-recumbent position. Pulse rate is 70 beats per minute. No pallor, no edema, jaundice and lymphadenopathy. Breast and thyroid appears normal. Systemic examination is within normal limits. On obstetric examination, inspection, abdomen is longitudinally distended with linea nigra seen. Umbilicus flushed with the skin. No scars and sinuses. Hernial orifice free. On palpation, fundal height corresponds to 32 weeks of gestation with flanks being not full. Symphysis fundal height measure 32 cm. Fundal grip suggestive of breech. Lateral umbilical grip on left side suggestive of fetal back. On right side suggestive of limbus. First pelvic grip suggestive of fetal head, mobile, 5/5 palpable. Liquor appears to be mildly reduced. Uterus is relaxed. Estimated fetal weight according to Johnson's formula is 2 kg. Auscultation, fetal heart rate heard in left spino-umbilical line, which is regular, 140 beats per minute. Diagnosis, she is a 30-year-old with primi gravida, 36 weeks plus 2 days of gestation with suspected FGR with singleton live fetus in cephalic presentation, not in labor for further evaluation and management.
How will you make a diagnosis of FGR in a particular patient? A pregnant patient come to you. This patient was diagnosed 4 weeks before, you said. At 32 weeks, first time you are examining a patient. How will you make a clinical diagnosis that she is it may be a small baby?
The symphysis fundal height was lagging more than 3 weeks now for her.
So before having a clinical examination, you should know the dates are correct.
Dates.
Many times we are seeing the patient for the first time. That is why your first trimester history and your dating scan is very important here. If the dates are very sure and there is a difference in the symphysis of height, fundal height of more than 3 centimeters, then you should suspect it could be a case of a small baby. It's not small for gestation, maybe physiological, maybe pathological. So clinical examination, how reliable it is. Because first thing is, see, first to understand the concept of FGR, you should know how to make a diagnosis of FGR. Whether it's a real FGR or it is apparent. So true FGR, and if that in FGR, what is the purpose? Why you are worried about an FGR?
Because
Why you are worried about an FGR baby? Why so much of discussion?
Ma'am, in FGR, they can have neurodevelopmental delays.
Yes.
FGR babies, they'll have decreased blood supply during the in utero, and even after delivery, they can have neurodevelopmental delays. They can
So in FGR
they can have
baby,
long-term sequelae.
the causes may be different. If the FGR baby with placental dysfunction, which have a compromised blood supply, may suffer from hypoxia leading on to acidosis, which may cause short-term complication in the neonate and long-term complication in the baby. That is the reason we are going to have a close monitoring. So the first step is how to make a diagnosis of FGR. Once you make a diagnosis of FGR, how to follow up the patient so that the baby is comfortable or there is no evidence of hypoxia or acidosis, and then when to plan the pregnancy. These are 3 important components of understanding of the topic FGR. Clear? Now you tell me, how are you going to make a diagnosis of FGR?
Based on the history and examination.
Yes, ma'am.
The history, we have to see for the risk factors, whether she had any previous history of FGR, a previous history of small for gestation, a previous history of any stillbirth is there or not. And
Any smoking history, any substance intake, malabsorption syndromes, then if she has had any is she hailing from high altitude, suffering from hypoxia, hemoglobinopathies, any connective tissue disorders.
Which compromise the nutrition which goes to the baby or oxygenation to the baby, maternal illness, which may lead on to FGR or previous history. Previously she produced a small baby. Previously patient is a chronic medical illnesses like chronic hypertension, pregestational diabetes, sickle cell anemia, APLA positive. So any maternal disorders which may compromise the fetal nutrition or fetal blood supply, probably she may develop a FGR baby.
What type of FGR is it?
this patient is a late onset FGR.
You have the previous, till what time she had concurrent?
Normal growth.
Less than 32 weeks is early onset FGR. After 32 weeks, it is a late onset FGR.
What's the significance? Why do you want to mean? What is the significance of having an early onset FGR?
Early onset FGR is...
It is easy to diagnose, but management is difficult, whereas in late onset FGR, the diagnosis itself is difficult, whereas since the period of viability will be very close, since they have crossed the period of viability, management will be little more easier. The risks of prematurity will be little less in late onset FGR.
Early onset IUGR, it is not only the maternal factor, it is the fetal factor also is very important. The baby may have problem or the placenta may have some problem. So what are the fetal factors which may cause early onset IUGR? Very early onset, say around 24 weeks we can diagnose a kind of symmetrical type of IUGR, what we called as earlier.
Like fetal congenital infections.
Yeah, aneuploidies, basically fetal aneuploidies.
Trisomies and trisomy 30.
Trisomies, disomies, any single
umbilical
chromosomal genetic abnormalities may be the cause. So we have to look for that in a very early onset IUGR, FGR rather.
In early onset, the placental disease is more, so they will be more associated with preeclampsia, will be more associated with early onset FGR.
Yes.
Whereas in late onset FGR, the placental disease is less.
So what are the placental causes of FGR? Why a placenta should cause FGR?
There could be infarction in the placenta, or there could be fibrin deposition. There could be single umbilical artery, presence of true knots, long cord. All those can precipitate FGR.
So basically the abnormal placentation. So the spiral arteries are not being invaded by the trophoblast. So there is a resistance in the blood flow, which may result in your fibrin deposition, your infarction, small placenta, and so on. And other than that, structural anomalies like your single umbilical artery or a velamentous incision of the cord, which may compromise the blood supply. So these are all the causes which usually happens in a early onset. Late onset also, most of the time it will be a placental dysfunction, where there is increase in resistance to the blood flow to the fetus. So this is the basic difference in the pathology. But once you make a diagnosis of IUGR, the follow-up will be almost the same. How we are going to follow up the patient to look for fetal hypoxia and acidosis. So the diagnosis, how are you going to make? Clinical diagnosis, you said? You go into the history, you look for any of the, why we are looking for these histories, there are some preventable factors, some modifiable factors are there, like your
Cessation of smoking,
nutritional deficiency or your substance abuse,
nutrition.
or modifiable. Previous history of IUGR, we may put the patient on
Serial
As-
follow-up we can.
No, you can give
Aspirin.
them aspirin. You can give them low dose aspirin. There's no role of isolated FGR, there's no role of heparin. But you can put them on ecosprin, 150 milligrams as early as
12 to 16 weeks.
12 weeks. Once the placenta, once you confirm the fetal heart also, we can start. Before the proper placentation happens, you can start ecosprin. So this is the modifiable factors. So we are asking for a detailed history. But first you make a clinical diagnosis. Yes, this is IUGR baby. How are you going to make a diagnosis?
Why do you want to know what type of IUGR it is? Whether it is asymmetric
Symmetric or asymmetric?
symmetric? Should you know the difference?
The growth of the baby, it will be uniformly small in asymmetrical.
So in your biometry, what all the parameters you look for in the biometry?
The abdominal circumference, head circumference, biparietal diameter, and abdominal circumference. If everything, all
And
the
femur
parameters
length.
will be- all
And
the
femur
parameters
length,
will
4
be less.
parameters.
If all of them are reduced, then it falls under symmetrical FGR. And if AC is only isolated AC, abdominal circumference is less than 10th centile, then it comes under SGA. And if it is less than 3rd centile, it falls under FGR.
So it is basically clinical diagnosis, obese patient, polyhydramnios, abdominal fat, BMI more than 30 is very difficult to diagnose. Apparently we can say yes, you can suspect it is a gross IUGR. Otherwise your ultrasound is the parameter we are going to diagnose FGR. So what are the ultrasound criteria to diagnose IUGR?
In Delphi consensus, they classified based on the Doppler's finding, that is early onset and late onset. Early onset FGR, that is
Early onset,
estimated
late onset is according to the gestational age.
according to
So what are the parameters you say? It is early onset IUGR.
the estimated fetal weight is less than 3rd centile with umbilical artery pulsatility index more than 95th
It's
centile.
not only estimated baby weight, it is the abdominal circumference, less than 3rd centile, along with your Doppler changes.
Like umbilical artery pulsatility index more than 95th centile.
Very
or
good.
Uterine artery pulsatility index more than 95th centile. And then there will be a
Or absent end diastolic flow.
That is as the disorder progresses, it is absent end diastolic and reverse diastolic flow. In a late onset,
have CPR less than 5th centile.
late onset CPR is the criteria. Also the growth parameters, it is 3rd to 10th centile, it is not less than 3rd centile is also we can have, but it is 3rd to 10th centile also we make a diagnosis. Along with that, one of the criteria.
If it is late onset, 2 out of these criteria should be present,
Like?
ma'am. If it is
So it is the growth velocity here. The growth velocity is very important. We have
If
at
it
least
is
2 or 3
less
scan
than
parameters
2
will be there.
quartiles,
Oh, the 2 quartiles means 50 centile, 50th centile decrease in the fetal growth rate. That is also making a diagnosis of a late onset IUGR along with your Doppler parameters. Same thing, umbilical artery, middle cerebral artery,
CPR.
ductus venosus, and finally it will be your umbilical vein. So these are all things. So to make a diagnosis of FGR, you should look for the umbilical artery and uterine artery along with the fetal growth parameter. And to have to say whether the baby is hypoxic or not, acidotic or not, you look for MCA, CPR ratio, your umbilical artery end diastolic and umbilical artery reverse diastolic flow. So this is how you are looking for the fetal affection. So how are you going to monitor? You 32 weeks you have diagnosed FGR.
We have to follow up the patient. We have to admit the patient, inpatient admission.
All the patient will admit.
No, ma'am. I mean, in our patient, she has got early Doppler changes, so it warrants admission,
High
ma'am.
resistance in umbilical artery, you want to admit?
Yes, ma'am.
Why do you want to admit?
It comes under.
Why you are worried about FGR monitoring? What is the risk of waiting? Or what is the risk of delivering?
Because when we wait, there's a more risk of stillbirth rate is high. No?
If
Yes.
What was the Doppler?
Then why you are waiting? If you say that risk of stillbirth is more, why you are waiting?
What is the
That
Doppler
has to be
report?
balanced with delivering the
Madam
baby
is asking some question.
preterm.
What is the Doppler report?
Ma'am, the Doppler showed estimated fetal weight less than third centile with she had umbilical artery pulsatility index more than 96 centile.
So please
With
understand,
oligoamnios.
when you are waiting for, when you are diagnosed with FGR and when you are prolonging the pregnancy, you are risking between the risk of stillbirth. When you are waiting, you are
Prematurity.
risking the, you are having a chance of risk of stillbirth is there. When you are delivering, the chance,
there's a chance of
prematurity, the risk of prematurity to the fetus is there. So you have to balance between the both. So for that, you have to closely monitor the fetus. So how often if you monitor? If there is no Doppler changes, only the growth is small. Because of the lack of time, we will summarize. Lack of this, we have to go for every 2 weeks the growth parameter, and every week she will go for a Doppler changes. Along with that, you look for
Biweekly NST.
amniotic fluid index also and other maternal parameters. It's not only the placental disorder, sometimes the
Preeclampsia.
mother may have an indication. So irrespective of the fetal condition, if the mother is at risk, see severe hypertension, severe preeclampsia, HELP syndrome, you will not wait. You will deliver irrespective
Immediate
of the gestational
delivery.
age. If it is not, if there is only the growth is less and other parameters are normal, there is no Doppler changes, you plan and deliver at, if it is the third to 10th centile, you can deliver at 38 to 39 weeks.
38
If it is
to
less than third centile, you deliver at, your last slide was very good, like show it, yeah. So you try to deliver by 37 completed weeks. But if there is a progressive Doppler changes, again you should understand, it is not that every FGR behave the same. Sometimes they will have a mild placental dysfunction, we continue to be a mild placental dysfunction. Sometimes it will be a progressive placental dysfunction causing increasing hypoxia leading on to acidosis. Sometimes it will be fulminant. If you diagnose, one day you have a higher resistance, after 2 days if you see there may be a absent flow and reversal flow. So it may be a fulminant also. So we have to know how often to follow. So if there is a mild changes, only high resistance is there, otherwise third to 10th centile of FGR, you do Doppler every week and growth every 2 weeks. Till it is 37 completed weeks or you find evidence of hypoxia or So what is the evidence of hypoxia and acidosis if the Doppler changes? It is?
There is a diesel
Is the absent end-diastolic flow, the reverse end-diastolic flow, or
there is a DV reversal.
DV reversal, absent forward flow or absent DV reversal flow. Depending upon the gestational age, if it is very preterm, you can wait till Doppler reversal. See, till 28 weeks, you can wait for the Doppler reversal. Till that time, you give the maturity to the fetus. If not, if it is 34 weeks and it is only reverse diastolic flow, you try to deliver. 32 to 34 weeks, reverse or end diastolic flow, you consider delivering depending upon your IUGR. And this time, you have to take the opportunity to cover them with steroids and magnesium sulfate, especially less than 32 weeks. You are having a major Doppler changes. You cover them with steroids. This time, what you are waiting for 24 to 48 hours, you are utilizing for steroid coverage and magnesium sulfate coverage for a long-term good prognosis for the baby. You got it? So you have to time it accordingly depending upon the gestational age and the Doppler changes. There's no, you have to individualize each cases. And depending upon the fetal behavior. And otherwise, what other parameters other than Doppler, it is your?
The CTG, NST we have to
see. NST.
And biophysical profile we have to see.
Biophysical profile. See how significant biophysical profile is. When you say yes, the baby is acidotic. What score you are giving?
4, if it score less than 4 in 30 minutes biophysical profile, if it is there, then fetal acidosis is there.
Less than 2 imminent delivery.
Less than 4,
delivery. Depending upon the Doppler associated changes, we can go ahead and go for steroid coverage and magnesium sulfate coverage. And other important thing is your computer CTG. Even though we are not practicing widely, that is upcoming because that gives tells you about the short-term
Short-term variability less than 2.6.
Tell us what intra-labor complications you'll anticipate.
There could be variable decelerations or sinusoidal. Some variable deceleration because our patient had oligoamnios also, ma'am. So there could be persistent variable decelerations or absent variability or late decelerations. All these can be encountered, ma'am. Intrapartum.
Not late?
They can have
Not
the baby
deceleration?
the fetus can have intrapartum asphyxia, meconium aspiration syndrome can occur.
How do you take care of the neonate? What complications they can develop?
The hypoxic ischemic encephalopathy can occur. They are more
No,
prone to-
short-term complication and long-term complication of a premature FGR baby. Preterm and FGR, short-term complication, long-term complications.
Short-term complication, these babies are more prone for HIE and intraventricular hemorrhage, prematurity-related complications. They are more prone.
Like all metabolic problems.
Hypothermia,
Necrotizing
So long-term it will
enterocolitis,
be
long-term they are more prone for neurodevelopmental
delay and cerebral palsy.
cerebral vascular
So you
accidents.
should know how to time it. So is there any contraindication for induction of labor in FGR baby fetus?
Sorry, ma'am.
Induction of labor, or you want to go for cesarean section directly?
No, ma'am, for
Until there is no
Golden rule. Yeah. So
absence
37
or
weeks,
reversal,
no Doppler changes.
Doppler changes is not there. We
And
can,
FGR, you can go for induction. If it is a major Doppler changes like your reversal of
absence or
end-diastolic
reversal,
flow,
then we'll go
or
for
NC
cesarean section.
or your DV changes, very preterm, you go ahead with the cesarean section. Okay, so you should know the diagnosis criteria, follow-up criteria, and timing of delivery. And you are risking between, this is the concept you should understand, you are risking between a risk of stillbirth and risk of prematurity. Done. Thank you. Any questions or doubt from the audience you can ask? From the presenter also. Any questions you want to ask? Yeah.
To do with the placenta?
we have to
Placenta
send
should
for
be
histopathology,
histopathology,
ma'am,
ma'am.
to counsel the patient for future pregnancy.